in the RV, you want to again try to get 3. It's RV in, RV apex, and RV OT. When you're going to pulmonary artery, you want to try to get an LPA, so that'll be 1. You want to try to get an RPA, that's another 1, and then you want to get a main PA. So that's 3 in the pulmonary artery, all right? And then you want to try to get a pulmonary capillary wedge sat, that should be hopefully just 1. You want to try to get a LV sat, that will hopefully be 1. You want to get an AO sat, that should be 1. And then if you can get an LA sat, you can cross over to the left side of the LV, or a left-sided sat, that would be 1. So it's 3, 6, 9, 3, 6, 8, 11, and 15. Okay, so that's why I usually ask you for 14 syringes, because a lot of times I will, assume it to be the same. All right. And the reason we ask for that many syringes is because that's the best way that you can identify a shunt. All right. And you want to take the highest sat in any of these places because that will identify. Now, obviously, that also means that your machine is working properly, that your calibration is correct. All right. And you don't want to have, if I measure 3 sats in the same place, then not 172, 178, 190. That will not help me a lot. So just recognize that that's the reason. So what are the ranges you're looking for? Between the SVC to the PA, under normal circumstances, it should be less than 5%. Okay? From the SVC to the RV, it should be less than 10%. From the RV to the RA, it should be less than 5%. Okay? So those are your saturations because of where the blood mixes, because of coronary sinus flow and stuff like that. All right? So those are the basic things that we look for. So if there's a step up that's greater than that in any of these places, we know that there is a shunt occurring somewhere. All right?
Do you always see a step up? Is there ever a shunt that is purely right to left?
No. Well, yeah. I mean, sure, you can have a pure right to left shunt, absolutely. There's always a little bit of mixing, left to right mixing. Most VSD shunts are going to be left to right. ASD shunts can mix, so there may be some right to left shunting. And that's the reason that the wedge, and so let's look at that for a second. So that's the reason the wedge sat is so important because, so if I have a pulmonary, if I have a wedge sat, that is theoretically coming from where? The pulmonary vein, right? That's the whole idea because I'm pulling that blood. The idea is that my wedge sat is pulling the blood from the pulmonary venules that are going to form the pulmonary vein. I'm actually drawing blood from there because I'm wedged in, all right? Because technically, so this is technically a pulmonary vein sat. So that is the most saturated blood that you're going to get. Now the pulmonary vein is going to go on to the left atrium, all right? So that should be the same. This should be the same. And so if I can just sneak into the left atrium through an ASD or a PFO, well then guess what? I can get a left atrial sat. I don't have to, and a lot of times you'll see me do that instead of getting the wedge sat because I'm so miserable at it that I'll try to get the left atrial sat and see if I can, get that. So that will, and we put that in the pulmonary vein group usually, right, in our system. So that would tell me that that is the most oxygenated blood. That left atrial blood is then going to go to left ventricle, which is then going to go to the aorta. All right? So, if there is mixing of blood in the right atrium, that's where a problem can occur. Because I'm just told you that I'm assuming the pulmonary vein is the same as the LA. Well, but what if I have both? Let's say if I have a wedge sat, and that is 98%. Okay? And I got an LA sat, and it's 88%. Well, that will tell me that there is a gradient from my pulmonary vein to my left atrium. Well, that gradient can only occur if there is mixing of blood from the right atrium into the left atrium. That there is a right to left shunt coexisting. Okay? Because if I measured it, I would say, oh, my left atrial sat is 88. That's kind of low. So yes, it is important to get a pulmonary capillary wedge pressure, wedge sat, because it allows you to see Now, what if I have a pulmonary, let's say if I got into the left atrium, then hopefully I can get the pulmonary vein. So maybe I can get a pulmonary vein sat and a left atrial sat. Okay? So if you've crossed over, then you want to do these two because you want to see, is there a right to left shunt? By the same token, if I have this and I have an LV sat, which is 88, well, that's a problem too. Because usually there will be some shunt between the right and the left. The question is, where is it? Is it at the LV level or at the LA level? And you're not going to be able to figure that out until you have some of this other information. Okay? So those are, because you know we're getting an LV sat. So that's the reason that a wedge sat is important, because it is one of the few ways that you can actually figure out if there's a right to left shunt. All right? In normal mixed venous, in the pulmonary artery, it's 75%. Okay? So that is your normal sat. Obviously a normal aortic sat, a normal air should be 100%, which means that your extraction ratio is 25%. Okay, so that is a normal extraction ratio in the heart for the right and left. And then quickly, in the last couple of minutes, last 5 minutes, we'll just go over some calculations of what we look for. So the reason that's important is because if I have heart failure, I am usually vasoconstricted. And as a result, my PA sat goes down. All right? So let's say if I have a patient who's 95% in the aorta, and they are 60% in the pulmonary artery, then I know their extraction ratio is 35%, and that would signal that they're in heart failure. All right? So now, the good news is that if I start to treat them for their heart failure, if I have a swan in place, I don't need to measure cardiac outputs. I can just measure this number. If this number moves towards 75, I know I'm doing the right thing, because I'm normalizing that state. So I must be improving their hemodynamic status. So I don't need cardiac outputs. I don't need anything else. I can simply do this. And we'll talk about, because cardiac output is the extraction ratio, basically divided into the pressure differences. Well, the pressure differences are what they are, but as long as my extraction ratio is going towards normal, I am okay. In patients